Thanks for the opportunity to present this case. The title of my case presentation is When in Doubt, Create a New Way In and Out. This is a novel approach to single-stick PCI with VA ECMO and cardiogenic shock. This case is a 70-year-old gentleman without any past medical history who presented to an outside hospital with shortness of breath and weakness after 2 weeks of chest pain. On arrival, the patient was hypotensive and urgently brought to the catheterization laboratory. His admission ECG showed anterior Q waves and a right bundle branch block. The patient underwent coronary angiography at an outside hospital, which by report showed a 50% terminal left main stenosis, thrombotic occlusion of the proximal LAD, as well as multivessel disease in the ostial left circumflex and mid-RCA. With wiring of the LAD, the patient developed PEA arrest and required CPR for 10 minutes before return of spontaneous circulation. An Impella CP was inserted, however, the patient had persistent hypotension requiring 4 vasoactive agents, and VA ECMO was initiated. On ECPella, the patient had 25 French multi-stage venous cannula, a 19 French arterial cannula in the left femoral artery, as well as an antegrade perfusion sheath, and a 14 French Impella in the right femoral artery. The patient developed bleeding from the ECMO cannulation site, required transfusion of 8 units of packed RBCs, and was found to have a lactate of 3 on admission with a creatinine of 2.3. The patient was then transferred for further management to our medical center. He was turned down for coronary bypass surgery due to being hemodynamically unstable. Pressors were weaned off while on ECPella, and dobutamine 5.0 was initiated. The patient's echocardiogram is shown here and shows anterioapical thinning consistent with a late presentation anterior STEMI and an EF of 15%. On ICU day 5, the patient was unable to wean off of VA ECMO or Impella due to persistent hypotension. The LVEF was unchanged at 15%, and a relook angiogram was performed. An uncomplicated RCA PCI was performed via the right radial artery with 2 drug-eluting stents. Despite RCA revascularization, the patient remained unable to wean off of VA ECMO or Impella by ICU day 8. He was then referred for PCI of the left main and left circumflex. However, at this time, the right radial artery had thrombosed due to prior PCI access site times 2. The left radial artery had thrombosed also due to a prior arterial line for hemodynamic monitoring. The right femoral artery had the Impella CP in place. The left femoral artery had an ECMO arterial cannula and antegrade sheath. The patient was also fully anticoagulated for VA ECMO. So our access site options were limited to brachial or axillary, percutaneous approaches, or ulnar approaches. And the question was whether we could avoid another arteriotomy. Should we exchange the Impella CP for a new PCI and single access Impella? What were some other approaches? So at this point, we decided to try a new approach using single-stick access for ECMO-supported PCI. We first confirmed that the patient could tolerate low ECMO flow by clamping of the circuit. This allowed us to run the Impella at a higher P level during the same point. The patient then had a large bore sheath that was combined with ECMO tubing and a Y connector. And at this point, we were able to attach this new system shown here with the Y connector to the native arteriofemoral cannula. Once we had this position in place, then we were able to reconnect the ECMO circuit after de-airing the sidearm of the Y connector, and then deliver a 7 French Q4 guide through the arterial cannula for PCI. This is the configuration as shown with the Y connector in place with the sidearm sheath available and also return of circuit. Patients flowing at 4.2 liters per minute at 4,000 RPMs in the ECPella configuration. Takes about 2 minutes to insert the Y connector and to de-air the sidearm. The patient then underwent uncomplicated left main to the ramus intermedius branch. You can see here us wiring through the arterial cannula. We then delivered our guide and were then able to wire the vessel and go ahead and perform PCI. This is the PCI approach to run through wires, kissing predilation, as well as delivery of a 3032 drug-eluting stent back to the left main ostium, which was optimized post-PCI. These are the final angiographic results. After PCI was completed, the guide and the sheath were then removed from the connector. The ECMO circuit was clamped, and an Amplatz wire was then introduced into the aorta to reestablish wiring of the arterial vessel. We then exchanged the arterial cannula with the Y connector for a new 19 French arterial cannula, and then reconnected antegrade perfusion sheath as well, and reactivated the ECMO circuit after removing the Y connector. This also took about 2 to 3 minutes. The patient also had the Impella CP removed with a post-closure technique at the same time. So we believe we've demonstrated a new approach to single-access PCI. This patient on ICU day 11 tolerated VA ECMO weaning, was decannulated on day 12. Cardiac status remained stable. Unfortunately, the patient on ICU day 28 was made comfort measures only due to poor neurologic recovery. We think this introduces a new era for single-stick PCI using VA ECMO to limit vascular complications and improve clinical outcomes for our patients. Thanks very much for your attention.